often. They come into the office for chest discomfort or some cardiac complaint. They have diabetes, high blood pressure, family history. They do fairly well on the stress test, don't have any signs of blockage, but you're still concerned. You're still concerned, because based on that, prototype and based on the recommendations, the guidelines are for treating moderately aggressively that patient as for the cholesterol. But in a lot of times I've done what we call, the ankle brachial indices, or checking the blood pressures in the arms and the legs. And if I find an abnormal, study, that means they're at a higher risk group, and I treat them much, much more aggressively. You push, their LDL to a much lower level, and very, very aggressive with your cholesterol-lowering medication. So, and you notify that patient that they're at high risk for a heart attack and a stroke. Now, further, if they do have discomfort on their legs, then you will go further. If it's limiting to them, then there are medications available. Of course, you can try, and you try initially a walking program. Get them to walk a little bit. You detail for them. It's not going out to the mall and looking at the windows. It's 45 minutes at a good pace. They're to walk to the point where they have discomfort, stop, get relief, start up again, and repeat that cycle for the duration of the 45 minutes or an hour. And they should do that 5 times a week. Many patients will get relief just by doing that. If they don't, then we talk about other options, and we do other tests to see where is the level of their blockage, how severe is it, so we can form a plan of action then for dealing with it with, minimally invasive means.
Absolutely, and I think that all of us, unfortunately, even when we try so hard to educate patients to get out and do more and more and more, it seems to be an Achilles heel. That is about the hardest thing is to quit smoking, eat right, and even exercise.
Sure.
To get people to just go and do that. And of course, if the patients are elderly or frail, it's probably somewhat difficult for them to do it, but in an able-bodied, relatively younger person, it really should be the absolute focus of our education to them, and then go on. And I think CTA has emerged, CT angiography certainly has emerged in the few years as a great diagnostic option. Before the emergence of CTA, we have gone on and taken the patients to the cath lab by traditional method, and have done somewhat slightly invasive procedures, put catheters into the arterial system and taken pictures. While we still do that, we have adapted to the point that we are doing it only when we are required to intervene, and shed some light on the emergence of CTA and where it has taken the whole arena of PAD.
Sure. CTA stands for computed tomographic angiography, and that's using a CT machine, which is quite sophisticated, not the early CT machines. Being able to give dye into or contrast media into a vein of the arm, wait to allow via timing for this to get into the arterial system, and then we take CT images which show us the arteries. We can actually visualize the arteries throughout the body with this, and it gives us, it's not only less invasive and easier on the patient, but it gives us a 3-dimensional image. It lets us look at this artery and measure it and look at how it twists and turns, whether or not there's calcium. And it may give us tremendous insight as to how we should treat the patient. Just in getting back to what Nick was mentioning earlier, many patients believe if they're not in excruciating pain, they should just ignore peripheral arterial disease. That is really very wrong. PAD has now been moved from being a risk factor to being called a coronary equivalent. If you have a diminished foot pulse, you're more likely to die of a heart attack than a person who's already had a heart attack and survived it. There's, in several studies, as high as a 20% incidence of either heart attack, stroke, or death in the first year after diagnosis, if untreated. So only a small part of the treatment is dealing with the leg symptoms. The big part is having patients quit smoking, controlling cholesterol and blood pressure, making sure that we place these people on appropriate medications, making sure that we screen to make sure they're not at risk of having a stroke from blockages in the neck or a heart attack from blockages in the heart. So if you have blockages in one part of the body, we know you're also more likely to have them in another. And it's that simple common sense approach that more and more are starting to learn now. And really that's a function of conferences like ours.
Absolutely. That is, if there is one key thing that all the physicians at various levels of involvement, including the primary care physicians or nurse practitioners or even cardiovascular specialists, at this stage still do not fully understand what a powerful marker of identification of the risk of patient, which is significant, far more than any other risk factor that we have known to tell clearly that the patient is at very high risk. You got to take the patient as a whole entity, not just be focused while taking care of the actual problem of an ulcer or leg pain is an important aspect, but looking upwards in the rest of the patient. And the same way when you identify heart problems or blockages in the heart arteries or blockages in the carotid arteries, the burden is on us to look further down and diagnose the other areas and alert the patient to the possibility of this disease and modify the risk factors very aggressively so the patient is not caught by surprise in the later stages of their life. And the other thing we keep hearing, unfortunately, even in this arena of a tremendous wealth of knowledge, both on the internet as well as other educational conferences or other campaigns, we still see there is a tremendous amount of amputations going on across the nation, both in our own state in different areas as well as across the board, which to me, and a good number of them get amputations without even having simple diagnostic tests like an ultrasound or an angiogram. Should that be really a tolerable practice anymore at this state of affairs?
In a simple word, no. And I know I helped write the article on that. Right now, and this is based on Medicare statistics nationwide, and it's worse in other countries, when one presents with critical limb ischemia, less than half even have pressures measured in their legs, and only about 1 in 5 has an angiogram done. Simply, they're told you need an amputation, and that's what has to be done. Now, that's no longer acceptable because in multiple trials, more than 95% of these patients could have their limbs saved. Now, that's very important because amputation is not a benign phenomenon. When you cut the leg off, it doesn't quit hurting. It continues to hurt. You have phantom limb pain. And so you've not cured anything. You've just simply gotten rid of the leg to stop an infection and to stop the muscle breakdown from poisoning the kidneys and the body. But these are some statistics to remember. It is stated that the morbidity is 20 to 30%. I would suggest it's 100%. Losing your leg is very morbid. However, the 20 to 30% deals with infection, deals with pneumonia, things like that. And of people who have an amputation, roughly 1/3 go straight from the amputation to a nursing home, never to ever walk again. The cost to society is profound. Amputation is in the second limb, so it's very morbid, much more morbid than any intervention. Secondly, it is much more expensive. It's more expensive in the index procedure in the hospital, but much more expensive over time because patients go straight from there to a nursing home, many of them. Those that go home have to change their homes. They have to build wheelchair ramps. They have to have special handicapped toilets. They have to do things that we don't think about. So it's more expensive. And then finally, it's more mortal. If we go to the best centers in the United States, not the average center, the best, a below-the-knee amputation carries between a 5 and 8% 30-day mortality. 5 to 8% of those people are dead in 30 days. Above the knee, it's 8 to 12%. Amputations are not benign. So they're dangerous, they're expensive, they're disabling, they don't get rid of the pain, and sometimes we need them. We need them because we can't revascularize the leg or it's too foregone, and if we don't take the leg off, it will poison the body. But I would suggest to you there are many, many, many patients who are having amputations that do have options. In fact, I've just written an editorial which is going to be coming out soon on exactly this phenomenon. There are many patients in this editorial. It was a whole series of patients who had no surgical options left, in whom we've achieved limb salvage, not for 1 or 2 years. These are patients now 13 or 14 years out who still have these same limbs. It's a very important thing. It's much better to save a leg than cut it off if we can. Amputation certainly is never going to go totally away, but I really do think a lot of people are getting amputations without appropriate workup. And what bothers me most is some of these patients have easily fixable blockages. You don't know what the blockage is unless you image in some way, shape, or form. Some of these patients have blockages that an early angioplasty fellow could treat, not the advanced interventionist, but a novice could treat. So I think that there's no longer any role for just simply going straight to getting your leg cut off, because to do a CT angiogram, for instance, is to simply start an IV and give some contrast media. That clearly doesn't carry the risk of an amputation, and it may indeed tell you who can be treated and who can't. So in all honesty, I think no, there's never an indication to go straight to amputation without understanding the anatomy.
Just to add a few statistics, in the United States, there's a very nice, interesting website. It's called the National Limb Loss Information Center. There's about 140,000 amputations done yearly. 80% of those are due to diabetes. And less than half those patients who got the amputation had any assessment at all of their arteries. And that's here in the United States with our technological advances, with all the CAT scans, the hospitals, everything we have here in this country. Every 5 minutes, a limb is lost without an arterial assessment.
Yes, these are definitely staggering numbers and staggering information that we have statistically. That clearly the burden is certainly we have taken that burden seriously for years, and I think we continuously make efforts to take this message on to medical practitioners at all levels, including nurse practitioners and wound care centers across the board. And certainly wound care centers, when they're in, definitely their level of understanding and differentiation of arterial and venous ulcers and what can be helped by an intervention, what can be helped by hyperbaric chambers or just plain simple wound care, is the knowledge is already there, but disseminating or getting that information out to the outside and getting out, we can't cry out loud enough. We keep talking about on TV programs ever so often, every month, literally pounding the same message again and again and again, stating that this is not a simple problem. This is a whole life-threatening, limb-threatening problem that changes a person's life drastically. So definitely, and the help is around. There are specialists like us and many other highly trained vascular interventional specialists in your arena. So for any of the audience that have an opportunity to view this program, and just don't get discouraged at any level. There is really no patient that is beyond help. All we can do is a simple diagnostic or a series of simple diagnostic tests to differentiate what is critical. And I want to take this opportunity to thank Dr. Walker for taking time, as well as Dr. Nick Cavros for taking time and attending this program and sharing some really valuable insights to our audience. And this type of information coming from the horse's mouth from the world's most renowned specialists is not easy to come every day, and we have a wealth of information here. I want to thank all the audience for tuning in and watching this program. I want you to welcome to tune in every month, the second Tuesday, to view this type of program about valuable cardiovascular topics. Good night.